Hello.
Hello. I asked, do he see us? He said, no. I said, why I'm wanking?
I see you.
Okay, hello. Hello, Frederico. Hello, colleagues. We are continuing our program in English because we have now the pleasure to host our distinguished guest, Frederico Bastos Goncalves, vascular surgeon from Portugal, General Secretary or previous General Secretary of Portugal Society for Vascular Surgery, and expert in aortic and vascular surgery. And also we are happy and lucky because in Serbia today was Zoran Rančić, our good friend and vascular surgeon from Serbia who now lives in Zurich. Anyway, we would host him in online option, but it was very good that he is in Serbia. And if you see that he is nervous, it is because he is waiting for his PCR test because he is traveling tonight. So he is waiting for his PCR test. So we are here because of TEVAR. This is our topic. And we would go through a lecture of Frederico, and then we will discuss some few cases and some other things together with Zoran and Frederico. Zoran, do you have any comment from the beginning?
I'm very pleased that I'm here and thank you very much to be a nice host. And pozdrav svima koji razumiju srpski.
Thank you, Zoki. Frederico?
Hello. Well, I'm very happy to be here also. Thank you to the Serbian Society. Thank you, Igor, for the kind invitation. And it's really nice to join the two of you, who I also have the privilege to be friends with. So I'm sure it will be a nice session.
Share your screen and we are looking for your talk.
Okay, I'm going to share it. Okay.
Okay, we see it very well.
All right, well, so the topic that I was asked to do today is TEVAR step by step. And this, of course, is a very broad topic, and I will just bring a few items that we can afterwards discuss if you like. Oops, sorry. Here are my disclosures. Of course, when we talk about the endovascular treatment of aortic pathology, it's a very mixed bag. So you have the standard simple thoracic aneurysms, but you also have the dissections, you have the dissection variants like intramural hematoma, you have the intramural plaque ruptures, you have also the transections from trauma. So there's a quite a diverse group of pathology. And of course, we know from experience also that one stent graft does not fit all the cases. And a few years ago, maybe we had only one option to treat so many different diseases. But nowadays, it's not the case. So we have stent grafts that have different types of design of the stents, with or without active fixation, with or without a proximal bare stent. We have different types of tip capture mechanisms to ensure more precise positioning. We also have conformable devices that will not force themselves upon the anatomy of the patient. And we also have devices that are able to partially only deploy to avoid a windsock effect, and also to reposition at the tip to reduce the risk of bird beaking. We also have devices that will position themselves asymmetrically into the aortic curvature to ensure less bird beaking effect, and we'll have mechanisms to avoid that adverse effect. And lastly, we have these dissection designed stents that will allow you to expand the true lumen of acute dissections without the risk of compromising the visceral aortic side branches. So there's not only one tool to fix aortic pathology, now we have plenty. An important aspect, first of all, is to determine whether TEVAR is actually feasible for the pathology at hand. And this is the way distribution of endovascular aortic procedures at my hospital, which I'm sure will reflect a lot of other places. And we see that the number of patients that actually are fit for a standard TEVAR is not very large, and it's actually reduced over the years. And this is because we now are less willing to compromise on suboptimal sealing zones because of the development of fenestrated and branched devices. So we have reduced our number of TEVARs and also reduced our number of EVARs, but significantly increased our number of fenestrated branched EVARs. And this is because we think the extending of the sealing zones will give us better durability despite a more complicated procedure at times. So the message here is compromising in thoracic aortic procedures, although sometimes may be necessary, often results in mid or late term complications. So we should be careful in patient selection. Here's something we used for the ESVS workshops on planning and sizing for EVAR and TEVAR. And this is sort of a step-by-step approach to sizing and planning. So the idea is that if you don't really take the time to plan ahead, you might find yourself in a very tight spot during the procedure itself. So the first thing you need to do is to have a proper workstation and be familiar with it. It doesn't matter what brand of workstation it is, whether it's free software like Horus, or whether it's a more sophisticated like Trimentio or the Aquarium workstations, as long as you're familiar with it. You need to have a recent CT of the patient with at least 1 millimeter slice cut thickness, and this should be at least 3 months old or less. And also, be familiar with the working sheath. This helps you not forget any of the details. And this is the sheath example that I brought here, is the one that we are promoting at the ESVS aortic pathway workshops. Another important aspect is when you look at the CT, make sure you choose the right window. This may seem simple, but sometimes it's not done. And the reason for that is that it really allows you to discriminate very well all the subtle changes in the aortic wall, and specifically to look at calcium very differently than contrast, so it will allow you to better decide your sealing zones. Another important aspect is to get the first overall picture, getting at least the axial view and then a coronal and sagittal views to get an idea of the anatomy and feasibility of the case. Then it's a nice idea to segment the vessel and look at the 3D reconstructions to get in your mind the way the anatomy actually presents itself. The next step would be to construct the center lumen line. And we know in thoracic pathology that the most reliable way to obtain length measurements is to actually make the center lumen line follow the outer curvature of the aorta, because otherwise you will lose a lot of length and the device will come shorter than you would expect. So it's an important tip to position your center line where you would expect the stent graft to be, on the outer curvature and not right in the middle of the lumen. And if you want to learn more about this aspect, I suggest that you look at this publication from the group of Stefan Ullon, which is very nice on the subject. The next thing you can do is look at the proximal and distal landing zones. So you would like to have at least 2 centimeters of sealing, proximal and distal, in a more or less cylindrical part of the aorta that looks undiseased. This would be the ideal. And it will help you to register on a piece of paper if you have a lot of calcification or thrombus that may compromise the proximal landing zones. And also how the aortic arch looks, especially if you are planning to deploy the graft close to the supraortic trunks. Following this, you can look at the vascular access. So is it possible to deploy the endograft? Is it possible to take the endograft there? And of course, we know a lot of the complications that come from large diameter sheaths come from access. We know this from the thoracic aortic pathology, and our friends, the cardiologists, are learning this from the TAVIs at the moment, that a lot of the morbidity and mortality that comes from these procedures comes from overlooking the access. So you should want a large enough access without excessive tortuosity to overcome and get the device where it's supposed to be. Then you take the length measurements, of course, and you should, I like to use the left subclavian artery as a sort of a baseline and then measure down from there. And you do the same thing for the celiac trunk. So we know we're in the margin of safety from those two vessels. And then in certain cases, we allow ourselves to cover the left subclavian artery if necessary and take the precautions for, we'll get to that in a minute. Then, of course, we need to take several diameter measurements and usually take them in two planes using centerline. And this will allow you to take the average of the two and have the most reliable possible diameter so that you can choose the graft accordingly, depending on the pathology you want to treat, with more or less or no oversizing of the graft. It's also a nice idea to take luminal diameter measurements to make sure you have enough space for the endograft, and also because if you have too much space where the endograft will be, you may expect there to be some movements that can be quite significant in the thoracic aorta due to displacement forces. So you may want, in these cases, to really have longer sealing zones and overlaps between components. Then, of course, you need to take the angulation measurements, especially in the arch, see what kind of arch you're dealing with, and choose your graft according to this. There are a few technical tips that I will talk to you later that have to do with this. But for sure, you need to register this and think ahead in your planning of plan B and C in case you have problems. Then, of course, the aortic side branches, that's very important, especially if you're going to cover a long segment. You want to make sure you don't cover large intercostal arteries, or if you do, if you have to, then plan ahead to reduce the risk of paraplegia. Another important aspect is to plan the Crm projections so you don't have to do several repeated injections in the OR. Most software workstations will allow you to do this virtually. And although we know that stiff wires and devices may change these angles slightly, in the arch, they don't do that so much. And it's kind of reliable that you plan the Crm projection in the correct way in the workstation, and then do the first injection already with this correct projection, which oftentimes means doing a complete lateral view. So that's something to consider as well. And lastly, make sure you select the device components for your plan, and also a lot of backups. And make sure you bring along all the necessary additional material that you may think is necessary if you encounter any predictable complications. So having all this in mind, you've completed the sheath, and I think you're ready for the procedure. So something that I just mentioned before is the paraplegia risk. We all are well aware of this problem in the thoracic aorta. And at this moment, I think most people will agree that at least in an elective setting, revascularization of the left subclavian is important in cases where it will be covered. because of extension to the sealing zone. So you may do this with transposition or bypass, but it's something not to be overlooked, especially in elective procedures. Then, of course, you should keep in mind that and have a good talk with your anesthesiologist beforehand to make sure you keep the blood pressures relatively high throughout the procedure to reduce the risk of intraoperative ischemia. And also give the patient enough hemoglobin, or make sure he has a good level of hemoglobin to ensure good oxygenation and reduce the risk of ischemia that way. Another important aspect is that you should always work in the room that is adequate for the procedure at hand. And I'm not saying everyone needs to work in a hybrid room. But if you have one, then these are the kinds of patients that should be treated there. And also, if you have available fusion techniques, that's also a very nice addition for TEVAR procedures, because it will save you a lot of time. So, depending on the complexity of these cases you plan to do, you may want to do them in a more sophisticated room or in a less sophisticated room. And if it's a very complex procedure and you don't have a sophisticated room, please consider transferring the patient to another institution for safety. I generally, nowadays, do all my aortic procedures percutaneously. I do this for the primary approach, and also I do this for all the redos. And especially for the redos, I think the added value is really very good, because there's not infrequent that you have wound complications if there's a re-exploration of the groin. So I do most of these cases percutaneously nowadays, and the difference between the percutaneous access and the open access is really enormous. And this is something to reflect upon. My preference for closure these days is the ProGlide system. I find it once you have reached that learning curve, it becomes very easy and reliable. And I've seen people use different systems, especially the Manta system and the ProStar, very effectively. But in my hands, for me, the ProGlide has very good results, and also allows you to do something that is handy, in my opinion, which is to reduce the sheath size by tying the knots partially and still keeping the access with like a 6 or 7 French sheath, but not losing the access completely. The advantage of this is that you reperfuse the limb, and because these large sheaths like 22 or 24 French may completely occlude the lumen, and if the procedure takes a long time, it's a long time of ischemia, and the postoperative course may be affected by that. Another important aspect is to also look at the anticoagulation. You don't want thrombotic events in any kind of endovascular procedure, especially not when you're dealing with the aortic arch and the visceral vessels. So what we do for protocol is that we give 100 units of heparin per kilo and then adjust according to the ACT, increasing another 30 units per kilo or 60 units per kilo, depending on how high the ACT is, to achieve a goal of between 200 and 220. And we find this is enough to keep the patient out of trouble and not too much as well. In special cases where we think there might be dislodgement of the graft, especially when we need to be very precise in the aortic arch, we use rapid pacing, and now we are using a direct left ventricular rapid pacing using the wire, the deployment wire, or my preferred strategy, a VCI balloon, so a vena cava balloon inflation that partially restricts the preload to the right heart, and so reduces the blood pressure. And we do this not by routine, but whenever we think it's necessary to be very precise. Another handy thing to have on your toolbox is anchors, because anchors may help you solve problems like bird beaking. So if you have this problem, it may be relatively easily solved with endo anchors. You also may want to use this when the sealing zone is not ideal. So to promote the sealing zone, to enhance the sealing zone. And I also have used it on occasion in patients where the lumen is very, very large, because I would expect there to be some movement over time. And the endo anchors will help me fixate these proximal and distal landing zones. So just a word on dissections. Before we were placing a TEVAR every time we had a complicated dissection to close the entry tear and then wait. And now we've moved to a more permanent solution that is hopefully more definitive. We started with the petticoat concept, extending with this dissection stent all the way down to the visceral vessels, and then moved on to doing this plus some dilation of the graft in the same procedure. And I will give you a word of caution that you should not use one of the compliant balloons like a CODA balloon at least not in the open stent part, but rather use a non-compliant 20 millimeter or so balloon that is much safer, because you may, with a compliant balloon, because these stents are so soft, you may end up rupturing the aorta, and that's, of course, something you don't want to do. Last word on IVUS. IVUS is a really nice addition, especially for dissections. You can perfectly see if the wire is in the true or the false lumen if you use IVUS. I think it's beyond a doubt. And this usually is not something, there's not a lot of doubt, but sometimes there is. And using IVUS will give you a lot less radiation, a lot less contrast, and security that you are correct in the lumen. It's also nice, if you already have it, to do a quality control, to see where the stent graft is and if it's correctly positioned to the wall. And also it can be used in different pathologies like this one, in a pseudoaneurysm for a traumatic dissection. So in conclusion, there is really no room for eyeballing and improvisation in the endovascular management of aortic disease. So we should make full use of technology and of knowledge, plan wisely, gain experience gradually, and know our own limitations. There are many diseases and many devices. If you choose the right tools for the right disease, that's not always obvious, so you should confer with your team and discuss every patient that you're treating. Using this step-by-step routine will help you plan all aspects of TEVAR, and in my opinion, it's the most well-spent time, inversely proportional by over a factor 10 to the time you can spend in the OR solving problems that you did not anticipate and really improving the quality and durability of your procedures. Thank you.
Thank you, Frederico. Thank you very much. So Zoran, I have 3 questions for you. Percutaneous or not? How do you induce hypotension? And what about anchor devices?
We are always using ultrasound assisted puncture. That means we are skilled in Evars and TEVARs to identify the origin of, to define where is going to be the puncture. So what we are always with ultrasound identifying the bifurcation of superficial femoral arteries, profunda femoris, and we are always going 2 centimeters above. the idea why we are going above in case that we are puncturing the artery, and as Frederico said, we are always using that, and after learning curve there is less complication, but there could be still the complication. We are going to puncture the superficial femoral artery with Viabahn and parallel go above to the hole where we made the hole, and we will put a stand graft to make to close the hole where was the initial puncture. So that means we are always using ultrasound. We are always puncturing 2 centimeters above the bifurcation, and this is what is a standard. That means what we are using, we start with it ProStar. It's too complicated. As Frederico says, we are using nowadays only ProGlide, and I think every hospital should define what they need to use. So not to mix with Mantra, ProStar, ProGlide. So define what you're going to use this, and then teach your residents to use only one closure device, and it will work. So whenever we are using above the 20 French, then we are using 3 ProGlides. So that means the position of the ProGlides will be 3, 6, and then the 12 arrow. So we are going to close before we tight up the suture of ProGlides from the first 2. We are going to insert the 3rd one, then the deploy 3rd one, put on the forceps, then close the 1st, 2nd one, and then after leaving a wire, we are going to close the 3rd one. So that means never put 3 ProGlides in the beginning. That means put 1, 2nd, then little tight, but not completely close the wound, and then go with the 3rd one. So this is what we are using. Then
do you have any exclusion criteria for percutaneous?
Yeah, what is the point is we have circumferential calcification, or we have full thrombus. Then we are going to say, okay, probably sometimes we are going to puncture SFA, superficial femoral artery, but let's say we are going a little bit higher. We have to be aware not to go higher than the inguinal ligament, because we can cause, in the situational trouble, we can result in the retroperitoneal bleeding. So try not to go there to puncture. But let's say, what is the advantage of ultrasound? Maybe there is always the plaque on the posterior wall, but sometimes can be the plaque on the anterior wall, but sometimes laterally is really good to puncture artery. And to be aware that despite the complication there exists in the percutaneous access, there is much complication if we are making cut down. And then if we have to make cut down, this is also interesting. Don't make a complete circumferential dissection of the artery. Don't put vessel loops or something to tighten the vessel, then just to dissect 1 or 2 centimeters of the artery, anterior wall of the artery, find the part where it's the good, and then put a needle or through the needle the wire. And then also, yeah, there is a different technique how to close this wound, but this is how exactly.
Frederico, do you have exclusion criteria for percutaneous? Do you use in all cases, or you exclude some cases, and why?
Well, we were more restrictive before, and at the moment, I think we are very liberal. So we, of course, if you have the entire superficial femoral, or the entire front of the common femoral artery is completely calcified, then that would be an exclusion criteria. But then in that case, you would probably go cut down, but for the external iliac, and also not puncture directly that calcified plaque, because otherwise you'll end up in an arterectomy. So I would probably say we do a 95 to or more percent percutaneous. We do just the same. We do everything with the echo-guided puncture. We actually managed to convince our cardiology colleagues to do it also, which was, I think, a great achievement. Well, we have a very nice technique to do it. Maybe we can show you some other time. It's really a nice way to make sure you get the right spot where you puncture. And by doing this, it's very, very seldom that you run into any kind of complications, even if in scarred or already fibrosed groins.
Okay.
So that's something interesting as well.
Thank you. And to come back to the second question to Zoran, hypotension during deployment.
Rapid pacing.
You do rapid pacing.
Yeah. We started to do rapid pacing very rare. We insisted on hypotension, but thereafter now we're using rapid pacing. So that's why the anesthesiologists prepare everything. Then at the moment we initiate rapid pacing, and this is what.
Does it matter the landing zone? Is it zone 0, zone 1, 2, 3?
In general, when we are going in the zone, let's say 1 or 2, we are using rapid pacing because there is a distance between the truncus brachiocephalicus and common carotid artery, and that we want to be more precise. In general, when we are making supraortic debranching, then we are just not using at all any rapid pacing. That means in case then we are going to land in the zone 0, then we are going debranching and then put it there, so no rapid pacing. But let's say zone 1 or 2, then in general we are using rapid pacing.
Yeah, these are most tricky zones actually to deploy.
Yeah, of course. And this is sometimes when we are making, if not transthoracal debranching, then the cervical debranching having more good sealing zone. As Frederico said, proximal and distal landing zone is the full exclusion of the pathology, but also from the long-term results, the key.
An anchoring device?
I will say maybe I use that in my life 3 times in thoracic aorta, but in abdominal we are using that more liberally, because if we have the short neck or hostile neck and we don't want, because of some contraindication with fenestrated or branch graft on, it's not possible to put a parallel grafts. In old patients we will say, okay, we have 8 millimeters long neck, and despite of that we are going with transrenal fixation and we are going to use endo anchor. So that means not so, we are always trying to have a good landing zone long enough, but in cases where it's not possible, it's too dangerous for the patient, because looking not all the anatomy, then the safety for the patients in total. Yes. So then we will use the endo anchors.
And Frederico, how often do you use in TEVAR anchors, and do you use it for prevention or for complications?
Well, we use it in less than 10% for sure. So it's something that we use only a few times because of price, because of cost. If it was free, then I think we would use it every time because it's quite easy. I've never seen complications with it, and it gives you an extra feeling that it's really fixated and there will be no migrations. I've used it a few times, well, maybe 3 or 4 times, to solve these large bird beaks. Sometimes you end up with this very uncomfortable position of the graft that you think may end up with problems. And in those cases, you can really push the bottom end of the graft against the inner curvature and fixate it with the staples, with the anchors. And this works very well. And also in the distal landing zone for TEVAR, sometimes you end up with not a lot of sealing zone between the end of the aneurysm and the celiac trunk. And in those cases, I've used it as well as prophylactic.
Yes, someone should turn off the microphone. And I have a question for both of you. You mentioned, Frederico, a very interesting thing, that you are now reducing number of TEVARs and EVARs on the cost of more FEVARs and BEVARs, which is probably related to the area in the visceral zone. And what about the supraortic area? If you have an aneurysm or whatever pathology that is extended more proximally, do you rely more on supraortic debranching procedures, or you go for endovascular, or you go for parallel stenting? Question for both, but first, Frederico.
Okay. Well, we have no experience in parallel stents except for bailouts. So we've had to do a few parallel stent grafts due to accidentally covering partially or completely the ostia of the left carotid, and also in cases where you really don't want to lose that left subclavian because there's a coronary bypass or something like that, but you accidentally do so, then I think parallel stent grafts in our experience will work. Electively, we haven't done that. We've done quite a few of the debranching of the supraortic trunks, and that we do together with the cardiac surgeons. And we do complete debranching from the ascending aorta with a bifurcated graft, and then do the TEVAR afterwards. We've just started in my hospital the program of the endovascular arch devices, but that's really premature at the moment. We have no experience.
And Frederico, don't use parallel stents, so we have Zoran. Zoran, do you use parallel stents?
Yeah, we are using a parallel stent grafts. And what we learned, just for someone who does not know what does it mean parallel grafts is stent grafts who is going outside the main stent graft to making perfusion of the supraortic vessels. That means from the brachiocephalic trunk, from the common carotid artery, or from subclavian artery. In general, we realize that more than 2 parallel grafts are not good. So that means we can maybe make carotidosubclavia bypass on the left side and put one parallel grafts from the brachiocephalic trunk to the zone 0, then from the common carotid artery to the zone 0, and then put a stent graft. But we realize if we put 2 or more than 2, that means 3 stent grafts, we have a high frequency of endoleaks. That means maximum 2 stent grafts. On the other side, when we want to revascularize the left subclavian artery and we don't perform cervical debranching carotid subclavian bypass, we're going to put stent graft below the left subclavian artery, put a parallel graft in a periscope position, and then extend the proximal landing zone between common carotid left and subclavian artery. So that means we're using relatively very liberal use of parallel grafts, and in supraortic positions are better results in sense of less gutter endoleak and the long-term results than in the renovisceral part.
And what about
Zoran? Sorry, can I ask you a question? What kind of stents are you choosing to do these parallel grafts?
Which kind of stent grafts?
Yeah.
We are always using Viaban. Das ist Viaban, it's from Gore. That means the stent grafts and then relined with the wall stent. So this is the standard.
Okay.
In abdominal part, sometimes we take Fluency, maybe take Advanta, but in general, we are always using parallel grafts with Viaban.
And what about the oversizing? Because the aorta, thoracic aorta is wide. So if you want to make 30% oversizing...
that means there is a formula that we are using. What that means? That means we take number of parallel grafts. That means 8, 8, 13. Then we make a summary divided by 3 plus half of the diameter of aorta. That means, let's make something like 30% oversize.
And do you have any upper limit of the diameter of the aorta that is not for parallel stenting? 45
is the maximum of the stent graft diameter. That means what is in accordance to this 45 with oversizing 30%, that's it.
Okay.
That means we never use custom-made for some companies for ascending. That means we're always using the biggest one diameter, is 45.
And since we are talking about the branching in the dissections, do you use often the branching, or Frederico, do you cover left subclavian often?
Yeah, well, it's not uncommon that in order to seal the proximal landing zone, the proximal entry tear, you need to cover the left subclavian artery. Since we are doing dissections mostly in complicated cases, the discussion always comes whether you should revascularize this left subclavian or not. Because we do that for elective cases, but we generally don't do it for, and we do it in a separate procedure. So we do it a couple of weeks before and then do the TEVAR afterwards. So in the acute dissections, it's very common that you cover at least partially the left subclavian artery and you just leave it. I think that's probably the attitude that most of the people where I work will take. The extension proximally then will lead you into a more complicated discussion of these non-A, non-B type dissections. We, in those cases, we choose to treat them as a type A dissection. So that means the cardiac surgeons will come and they will do hemi-arch replacement and a frozen elephant trunk. And then we will either just leave it or complete it further below if necessary.
Yeah, we have cardiac surgeons in the other room. Maybe they're listening to this. I don't know what would be their comment. In our experience, very frequently, if we want to have a 2 centimeter landing zone, we have to go more proximally, and we had a lot of carotid subclavian bypass in dissections, even carotid subclavian as well. And we don't have this policy of doing cardiac repair because of type B that is, close to the arch. Zoran, how do you do it?
In general, we have to be aware if what we see on the axial CT, when we make reconstruction of the CT scan, what we see where the end of where's the beginning of the B dissection, we have to be aware the quality of the artery 1 to 2 centimeters is not well enough. So despite it looks very nice on the CT, that it might be that it's not so good. So we are doing all this procedure in local anesthesia in situation of acute B dissection with not adequate landing zone to deploy the stent graft below the left subclavian artery. We will cover that without any reconstruction. We are doing that in local with analogous sedation. We are looking what is going on with the moving of the legs. If it is fine, then we will say, okay, then we will leave it like this. But I also agree with Frederico, in case there is a most challenging B dissection, then I think that maybe we did twice carotid or carotid subclavian. We will ask the cardiac surgeon to make, because we were the same clinic 2 years before, so we will ask them to make elephant trunk or something like this, and we will then do it later. And what is important in case of B dissection after putting a stent graft, I don't know what is policy in your centers, but last 2 years we're starting to perform CT angio immediate post-operatively, because after deployment of stent graft, that means some below part who was not complicated might become complicated. And we see several times we see occlusion of the renovisceral arteries, and then not wasting the time before the acute abdomen develops. So there is a renal insufficiency. That means if we see then new onset of occlusion of renal arteries of mesenterica, we do it immediately after putting a stent graft. That means immediately after CT angio, after procedure TEVAR, we are going to CT angio, because this is acute situation, all acute aortic situation after deployment of stent grafts. We are making this and coming back in the theater if it is necessary to put a stent. It is not common, and there is a lot of people who argue about this, that a lot of toxicity of contrast injection and something, but we think it is safe for the patient.
Thank you. And
why not do a cone beam? Do you have cone beam CT in the OR? Because that could be
we have that, but
even
we don't,
better, no?
Yeah, it is, but we are not familiar. We try to do it, and I think before you learn to interpret this, you have to know this. And we are not doing that in elective cases, and also in general, we are not using. That means all acute lesions ends up with one CT angio. The same is for the rupture of B dissection, for the rupture of aorta. We are always going to the CT angio. We don't use this in the operating theater. We have possibilities, but I don't know, we don't use it.
I will ask our technician to share my presentation. It's already here. Before we start, just a question for both of you. In Rotterdam, there will be a session about dissections, and we will discuss so-called new criteria for treatment of non-complicated dissections, like entry tier, diameter of the true lumen. Do you use this to treat non-complicated dissections earlier, or do you believe in this? Just short answers.
If I have to answer, because I got a negative PCR test, that means I can normally flight. So this is good. Sorry that I used the mobile phone. Sorry.
No problem.
The second is, in general, we don't put in an uncomplicated BD session, we don't put a stent graft. But if we see during the time that there is that we cannot have control of the blood pressure, we have a rapid expansion, we always make first, third, 7th day. If we there see increase in the diameter, or then we are going to put a stent graft. In an uncomplicated general, not. Answer is no.
Yeah, and you, Frederico, and your team?
I think it's exactly the same. Very few exceptions. We do it only in complicated, and that means malperfusion. And just a few cases where there's rapid expansion or uncontrolled pain or hypertension, then we do it as well. But it's the exception and not the rule.
Yeah, we have 5 more minutes. I have just several questions for you regarding the case presentation. Do you see the presentation, Frederico?
Yes.
Yes.
So this is obviously a kind of infected lesion. It's a 77-year-old female with acute presentation of chest pain. She had a moderate comorbidity, but she had age, and she had this kind of irregular aneurysm that may be infected. Would you go for Evar or for open? For TEVAR or for open? Frederico.
Okay, Frederico.
Well, that's the nightmare that you don't want to see, right? That's like, well, I would go for endo, because it seems ruptured, and it's the most effective way to take a patient out of a rupture situation is endo, and deal with reconstruction afterwards. We have done this before using pericardium bovine patch graft to make a new aorta. But of course, this is a bad case any way you do it. So
yeah, Zoran, you agree, huh?
We no doubt that it's only the TEVAR.
Yeah, we did the same, but then she came back after 3 months with exactly what you said, Frederico.
And did you stop antibiotic in between?
Yes.
I think that's the point. We never stop this, and we have these people included in one vascular controlling thereafter. This is some study. We're doing PET scan, and we never stopped it. In this case, depends on which bacteria. Did you isolate any bacteria?
No.
No, nothing. Okay, good. But we will go for antibiotic at least 6 months.
6 months, okay. That's a good point. But anyway, endo would be probably the good bridge. And this is a patient with acute presentation, back pain, no malperfusion, no rupture. And this is actually the dissection that we already discussed. So probably you would not go for intervention in the acute settings. Or you would?
What we discussed is not as you were showing.
So we discussed one thing, but now we have a case.
I think the diameter is... it is more than 5 diameter. I don't know what's the diameter of this part. I don't know. Maybe I will make this 1.3, and if there is a little bit increase, I don't see the landing zone, I will go for TEVAR, because it does not look nice. It's really huge.
Okay, good to know. This is a patient, the elective patient with Bental previously, and now he has a post-dissected aneurysm after the Bental procedure and after the aortic ascending aorta repair. So, what is your policy in these patients who have?
What's the diameter?
Diameter is about 60, I think. So the problem is proximal landing zone. You cannot go for total. You can go for total debranching, but you have to go for wrist sternotomy. You have a dissection in the arch. You have a complete aneurysm in the thoracic aorta. You probably see this kind of patients, with previous cardiac surgery, and then you have to extend distally.
But where should be the landing zone? You don't have. Where is the dissection? Is the acute dissection?
It's a chronic dissection.
Chronic dissection.
Yes, and dissection goes completely until distal, until the iliacs. So the whole aorta is divided distally. There is the aneurysm is in the proximal part, in the descending thoracic part. Distally diameter is not so big, but still there is a dissection, and all branches are going from the true lumen, both venous and mesenteric superior and celiac trunk. But the problem of landing zone proximally is the most convenient landing zone would be in this graft that was placed by cardiac surgeons.
So where I work, if the patient is fit for surgery, this would be a resternotomy, cervical debranching with a frozen elephant trunk. And then we would look at how the false lumen and the true lumen behaves over the course of like a month or so. And then plan probably a fenestrated graft to treat the visceral segment if needed. This would be the way we would do it.
Okay. Zoran?
Yeah, maybe if the patient is prohibited to make resternotomy, maybe inner branch from an arch because he has a very nice curvature of the arch, or maybe in situ fenestration. We never did it, so we will discuss that with cardiac surgeons. I don't have any idea.
Yeah, it was nice to discuss with two of you, but we don't have any more time. Maybe there is a question from audience. Can we see the question, maybe? Pitanje iz publike ima.
May I ask?
Yes. Just one question.
Okay. Thank you, Zoran and Frederico, for joining us. It was really an excellent webinar. I enjoyed it. I just have a question. Maybe I missed it but what is the protocol you use for the uncomplicated dissections to follow them? What is your institutional protocol, both in Portugal and Zurich?
Yeah, please, just a brief answer.
Yeah, for uncomplicated, we would do CT at 2 weeks, then at 6 weeks, 3 months, 6 months, and then yearly after if nothing's wrong.
Uncomplicated for us, no stent grafts initially, first, third, 7th day, 2 weeks thereafter, and then regularly control if no complicated or there is no change in the morphology or in the diameter of the false true lumen. So in general, not putting a stent graft. There is a studies they want to show if there is better to put a stent graft. As Igor said, it's going to be discussed in Rotterdam, so you can join and see what is the new.
Yeah, so continuing in Rotterdam.
Something like this.
Yeah. Thank you, Frederico. Thank you very much for sharing.
Thank you.
Yes.
It was really a pleasure. Thank you.
Ciao,
Yes,
Federico.
take care, and we let Zoran go. Okay, goodbye. Pauza od 3 minuta i nastavljamo sa karotidnom sesijom.